Yes, I think we can go ahead and get started. I would like to welcome everybody today to our Psychiatry Department Grand Rounds. I am Carrie Roby. I'm one of the fourth year chief residents playing the role of Dr. Jensen today. He usually does this. But I get the auspicious privilege of introducing our lecturer today, Dr. Michael Blue. Before I do that, a little bit of housekeeping rules. If you guys can just make sure that you are muted, and that way we won't get good echo and feedback and all the crazy noises that can happen when we do this virtually. There is going to be a time for questions kind of about halfway in. Dr. Blue was telling me, if you're comfortable doing it and you want to unmute and speak, by all means, feel free to do that. Otherwise, we can utilize our chat feature and you guys can submit questions via Dr. Blue. That has been what we've done in the past. That works well. So on to the good stuff. Our lecturer today, Dr. Michael Blue, board certified in psychiatry and forensic psychiatry by the American Board of Psychiatry and Neurology. He was a graduate of Meharry Medical College School of Medicine in Nashville, earned his doctorate of medicine with honors in 2006, then completed his residency in psychiatry at Harvard Medical School in 2010. While at Harvard, he was selected as administrative chief resident at the Harvard Medical School Psychiatry Residency Training Program. Received a number of academic awards during his training, such as a Psychiatry Residency Training Program 360-degree Professionalism Award and the Residency Training Program Best Research Paper Award. But that was not enough for Dr. Blue. After he graduated, he went on to a forensic psychiatry fellowship at Tulane School of Medicine in 2011. He is also the former associate training director of that program there at Tulane and the former clinical director of the Secure Forensic Facility at Eastern Louisiana Mental Health System Forensic Division Hospital. He is currently, and we are blessed because of this, the attending on one of our units at Woodridge Hospital, and also serves as the medical director and CEO of Visions for Better Life LLC, as well as an assistant clinical professor still at Tulane University School of Medicine. So we are very grateful to have you today, and I will turn it over to you, Dr. Blue.
Thank you for that awesome introduction, Dr. Roby. So I appreciate that. All right. So today, Grand Rounds, we have a couple of different topics. The first one is more germane to clinical responsibility that residents are going to see, as well as test material that you're going to see. And it has to do with medical decision-making capacity. And then afterwards, after we cover that, we're going to get into a little bit of an introduction to forensic psychiatry and the differences between a clinical and a forensic psychiatric assessment. So it's very important for you to know that I don't have any relevant financial relationships or commercial interests to disclose. And just in case you missed that, we made sure to put it in twice. The key components, so the objectives of our discussion today are going to be to state the key components that make up medical decision-making capacity, to state the necessary steps to assess decision-making capacity, and to be able to perform a thorough medical decision-making capacity evaluation. So some important differences. A lot of times you'll hear capacity and competence used interchangeably. The truth is that they really aren't, though. And so there's some key distinctions that I want everybody to be aware of. And some of these distinctions are tested on. So you'll see these on the PRIDE exam, for example, on your board exam. And so you just kind of be on the lookout for that. So medical decision-making capacity is a clinical evaluation, okay? But competence is a legal, judicial determination. And that's the major difference that you really want to be able to take home. So as clinicians, we will assess capacity. The court will determine competence. And so I spell out some of the major differences on this slide, whereas you see capacity as medical versus competence being legal, an MD assessment for capacity, whereas you usually have a judicial determination for competence. Medical decision-making capacity evaluation takes place in the here and now, and it tends to be brief in time with respect to how long it can take to establish someone's legal competence or lack thereof. And medical decision-making capacity can fluctuate, and it's task-specific. I also want you to remember that it's very key. So a person can have capacity for a simple medical decision, but may lack it for a more complex one. And we'll get into that a little bit later. I want you to look at it kind of like a sliding scale as opposed to a complete step, okay? Competence is a semi-permanent determination. There's usually a sunshine date where competence has to be reassessed by the court. whereas capacity is more fluctuating, okay? And then in the sense of a medical decision-making capacity, we can usually find a substitute decision maker versus a guardian if someone is deemed legally not competent to be able to make their own medical decisions, okay? So we define medical decision-making capacity as the ability to understand and appreciate the nature and consequences of either healthcare decision, and you have to be able to understand the benefits, the risks, the potential harms, as well as alternatives that are available to the person. And what I'm going to do for you today is we're going to start off discussing the clinical concepts, but I'm actually going to operationalize this for you so that you can actually walk through specific questions and specific steps as you assess this when you're asked to do a medical decision-making capacity evaluation or a consult. All right, so let's go through each of these concepts. Let's talk about first the ability to understand, right? So what we want to assess is the patient's capacity to generally understand the medical problem that they're facing and the nature and the consequences of allowing that problem to progress versus intervening with respective treatments and not intervening. So they want to know that they're familiar with their options for care or their alternatives, and that they understand the potential risks and benefits of each option as compared, okay? So ability to appreciate. A lot of times when you hear these standards, they use language that sounds awesome, but you're not really sure what it means, you know? So in this case, the ability to reason, attach personal meaning, and justify the options and choice. Now, let me stop here just for a minute, because a common rookie mistake that we make in these assessments is that we expect the patient should make a choice that's consistent with our values and what we think is best for the patient. But a patient can possess medical decision-making capacity as long as they are making a choice consistent with their own values. So they're allowed to disagree with the clinician with regard to what they think is best for them. They may have different priorities than we do, okay? And that they're able to demonstrate the elements of free choice. So we don't have undue influence, they're not being controlled by someone else or another, or the mental health condition itself can have an undue influence in this case. So if they have a formal thought disorder and they're having difficulty organizing their thoughts and expressing themselves, that's an influence of the mental health condition itself, okay? And that the reasoning is consistent with the patient's known values. So I'm going to harp on this a couple of times through this evaluation, because the best person suited traditionally to assess medical decision-making capacity isn't necessarily a psychiatrist. It's the clinician that knows the patient the best and has a longitudinal relationship with the patient. And so I'll come back to that a little bit as we continue to progress, okay? Because they're the ones that are going to know what the patient's values are and whether or not this reasoning, this current reasoning, is consistent with those expressed values in the past. All right, so for capacity, a patient has to be able to demonstrate an understanding of the problem and its options. They have to be able to reason between those options. They have to be able to appreciate the personal nature of the options and choose that's consistent with their own values, not necessarily what we may think is correct. And that's a common trap that we fall into. And they have to be able to communicate that choice that stays stable over time, okay? This is another major kind of fallacy or trap that our friends on the medical side tend to fall into a lot, okay? They assume that the presence of a certain psychiatric disease or disorder means automatically that the person lacks medical decision-making capacity. And this is far from the truth, okay? From a clinical and a legal standpoint, capacity and competence are presumed. So everyone in the United States is presumed competent to make their own medical decisions. From a clinical standpoint, they're presumed to have medical decision-making capacity unless examined and assessed and documented otherwise. And the onus is on us as clinicians to demonstrate that lack of capacity through a thorough medical decision-making capacity evaluation, okay? So, 1, presume capacity. If any red flags are apparent, then we assess the capacity. And you remember that sliding scale that I mentioned to you guys earlier. I'm about to teach you a little bit more about that and how to operationalize that. Because the more invasive the medical procedure, the more serious the illness, the more complex the medical decision, we have a higher expectation of capacity and competence than if there are lower risks, lower side effects, lower acuity, okay? So some of the red flags that we look for when we say, we need to assess decision-making capacity, or we should be concerned about it. If there is a significant burden of mental illness, especially thought disorders. Remember when I mentioned disorganization of the thought process earlier? If we notice that, that could indicate that we really need to assess capacity and they may be impaired with regard to their medical decision-making capacity. Dementia, delirium, either end of the age spectrum, so very young patients versus very elderly patients, and polypharmacy because of the effects of multiple medications on mentation. So other red flags would include making a choice that's not consistent with their prior expressed values and choices, okay? This is part of the reason why the clinician who's best suited to perform these would preferentially have a long-term relationship with the patient. It's not always an option, but preferably that would be the case. Making a choice that has a high risk of harm and a low risk of benefit, and then refusing a treatment that has a high risk of benefit and a low risk of harm. So those are just red flags. They don't mean that the person doesn't have capacity, but they indicate they may not, and we should be vigilant in our assessment. So if the patient doesn't have capacity, we have to find a substitute decision maker, okay? Notably in New Hampshire, the only legal authority to do that is through a durable power of attorney for healthcare, okay? New Hampshire's got a couple other interesting differences when compared to the rest of the country that I'll get into a little bit later. So where a patient lacks capacity and there's no substitute decision maker, the only legal authority is through a temporary court-appointed guardian, and this can be very time-consuming. So I just kind of spell it out here. Presume capacity unless red flags exist. If they exist, then we assess capacity to determine whether they lack it or whether they have the capacity to make the medical decision. So here's where we start to get into the operationalization of it, okay? So the appropriate setting to allow free choice should be a quiet setting. It shouldn't be rushed or hurried, okay? There should be adequate information available to both the doctor and the patient. You want to avoid inappropriate influences, and I'll get into that in a minute, where you have relatives that are speaking more than the patient, et cetera, or the doctor is doing this. A lot of times we like the way that we sound, and so we're doing more talking than the patient is. That can be an indication that there's a problem. And there's an old saying that you couldn't or you shouldn't assess decision-making capacity standing up. So you want to be at eye level with the patient, okay? So you want to collect as much information from the team. What was the reason for your visit to the patient? So I'm pretty sure a lot of you have had the unpleasant experience of coming into a psychiatric consult. Patient has no idea that psychiatrist's been consulted. As soon as you introduce yourself and they find out that you're a psychiatrist or you're a psychiatry resident, they feel insulted, right? It's like, oh, so now they think I'm crazy, And so preferentially, the treatment team that's consulted us has explained to the patient that they are consulting us and why, okay? And if that hasn't happened, then we have to go ahead and do that educational piece on the front end with the patient. So Mr. and Mrs. So-and-so, I've been asked to assess you specifically for your ability to make medical decisions for yourself, specifically the decision to, and then we're going to mention the decision in question. So medical decision-making capacity is task-specific. So it isn't global in a sense where, well, we need you to assess this patient to see if they can make medical decisions. Well, let's refine that question a little bit. What medical decision do you want, are you curious about? What specific medical decision the patient may or may not have capacity to make? And that's the way we approach it with the patient, because it is task specific. They can have capacity to make decision A, but lack it for decision B, okay? This is where I really miss kind of having an audience, because I can kind of get feedback to make sure people are getting it. So my apologies for that. All right, so the cues that the process is not appropriate, all right? So if other people, such as the provider, families, or friends, are speaking more than the patient is. If the patient doesn't appear to be connecting with us, they have poor eye contact or poor body language. Now, in certain cultures, eye contact can be considered disrespectful, so I'm gonna give that advice guardedly. Some people view eye contact as something that's very intrusive, and it may not necessarily mean that they're not connecting, but in the majority of people, it's one of the indicators that we can look at. And then if the patient lacks important information or appears to be misinformed, So when you ask them about the nature of the healthcare decision, they seem to either not understand the risks or have over or underestimated them or don't have an accurate description of the proposed treatment or intervention. Okay, at that time, that's an opportunity for us to take the time to educate the patient. Sometimes you'll run into a situation where there's been a power struggle between the patient and the treatment team. And the treatment team may become exasperated with the patient because they're not making choices consistent with what the clinical team thinks they should be. And so almost as a reflex and almost a punitive reaction, in some instances, the psychiatric consult is placed, and then we're asked to assess them. And the patient really has never been explained the ins and outs of what's proposed up to that point. And so it's an opportunity for us to potentially educate the patient at that moment, okay? So best practices for this, preferably a long-standing relationship with the provider, even though I know in the context that's not always possible. The provider should understand the decisions to be made. So oftentimes we're discussing with the surgical team, with the medical team, et cetera, the specifics, the ins and out of what it is that they propose, so we can understand it and maybe potentially explain to the patient, or at least verify that the patient understands it, right? That we don't show undue bias about the options, okay? And this is another trap sometimes that the primary treatment team can fall into. They have a way that they want to go with the treatment plan. They weigh kind of the advice heavily on that, and that the patient senses that, and they can be resistant. Maintain appropriate eye contact. It shouldn't be a hurried setting, and the patient should be speaking at least more than half the time in a good medical decision-making capacity evaluation, because they're responding to us, okay? So you remember I mentioned it's a slope, not a step. It's specific to the medical decision at hand, and one can have capacity to make a simple decision, but not a more complex one, okay? This is another big one, and sometimes you'll see this on test questions, right? Does a medical decision-making capacity evaluation require a psychiatrist? So the sneaky and short answer is no, it doesn't. Anyone who's trained to do it, anyone who's a physician can perform an appropriate.
Dr. Blue?
Yes.
This is Brian. I believe you're brushing your microphone, possibly with your left hand. I'm not sure, but could you touch your, not touch your laptop until you're advancing the slides?
Sure, okay.
Sorry about that. Sorry to interrupt.
Is the noise still there or is it gone?
It's gone. I think you're covering your microphone on occasion.
It could be, because I am touching it sometimes. Okay,
Okay.
Thanks for the heads up. I appreciate it. All right. So it doesn't require a psychiatrist in order to do it. The best provider is the one that has the best knowledge of the patient and the best knowledge of the decision to be made. Sometimes it takes more than one visit in order to assess it, especially when we suspect delirium, because the patient's level of attention and concentration and alertness can fluctuate over time. And it requires listening skills more importantly than speaking skills. Did I avoid the brush that time? I think so.
You're good. Worked out well. Thank you.
So when we speak to the patient, we want to avoid medical jargon. We want to use proportions and percentages when we talk about the risk. So a lot of times when you get into the specific risks as they're described in the medical journals, et cetera, patients' eyes glaze over, and we've lost them. All they hear is like, wah, 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 so we want to not use the jargon, use basic terms, use percentages so that we get an idea of how the patient is assessing the risk versus the benefits. And we want to try and sit at eye level with the patient. All right, there's a little curves algorithm here that kind of helps you to be able to understand some of this, and I'm going to walk you through it. So the C stands for communicating and choosing, the U for understanding, the R for reasoning and the capacity to reason, the V is for their personal values, which is why we kind of prefer to have a clinician that has a long-standing relationship if possible. The E stands for, is this an emergency situation? And I'll get into that in a moment, where we may have to act when we're unable to assess capacity. And the S stands for stability and decision-making capacity versus requiring a surrogate, okay? So, C, can the patient communicate a choice, okay? If not, if yes, we proceed, okay? But if not, is there a way that we can assist the patient with communicating a choice? If someone has an aphasia, for example, but they're still able to communicate via other means? If no, if they're unable to communicate with us, then by definition, they already don't possess medical decision-making capacity. It's one of the critical elements that we have to assess whether they do or not. Can the patient understand the medical decision, the options, the risks, the benefits for treatment? Okay. If yes, proceed, go on. If not, let's make an attempt to educate the patient. All right. This is our opportunity sometimes where discussions have broken down. Perhaps the patient could understand if given the opportunity. We provide that. But if adequate discussions occurred and they lack capacity, then we're going to need a surrogate decision maker. Okay. All right. So this is some of the specific operationalization that I want to kind of provide to you. Okay. So here are some specific questions that you can ask the patient just to assess their understanding. What is your present medical condition? Notice how that question gives the opportunity for free discussion, right? It's not a fill in the blank per se, or a one-word response. It gives us the ability to understand the thought process and understand how well the patient really understands what's happening. What treatment is being recommended for you? What options do you have? What do you and your doctor think will happen if you exercise option A, B, C, etc.? And what do you and your doctor think will happen if you choose no treatment? Okay? All right, R. Can the patient reason between the options? So what option for care do you want? And why would you choose that option? Is there anything else that might be affecting your decision? Does the patient choose consistent with their set of personal values? What do you think will happen if you make this choice? Help me understand why you decided to choose. So this is where the patient really has room to potentially disagree with the clinical treatment team, but that may not necessarily indicate that they lack medical decision-making capacity. If they're able to articulate a logical reason that flows consistent with their values, even if we disagree with it, they would still possess medical decision-making capacity. Okay. If they're unable to give us a logical flow, if it doesn't track, it doesn't seem to make sense, it seems contrary to what they describe, then we would question it. Okay. And then, is this a medical emergency? So this is the E, right? If it is, we're going to proceed to save life and limb in that urgent moment. If not, then we have time to find a surrogate or work on methods to assist the patient with achieving. So let's say that they have a psychotic disorder, and the psychosis is so bad they have, they're disorganized in their thought process, but we may be able to initiate treatment, thought process becomes more organized, then they have an opportunity to make a more informed decision, okay? All right, are the patient's decisions based on the values that are stable over time? Remember when I mentioned that sometimes it takes more than one evaluation in order to be able to do this? This is particularly, I like to mention delirium because it kind of fits that paradigm perfectly. If yes, then we proceed. If not, then we need to understand why their decision-making isn't stable and if there's some intervention that we can take to make it more stable or not. All right, so here are some additional questions to help to determine the ability of the patient to understand and what they understand about the treatment and the proposed options for them. So what's your understanding of your condition? What are the options for your situation? What's your understanding of the benefits of treatment for you? What are the odds that the treatment will work for you? And a lot of this can be, before I go on a little bit further, a lot of this can be an indicator of how much discussion took place before we got there and how much the person really truly understands. And it could give us the specific knowledge gaps to fill for the patient if they need to be, okay? What are the risks of treatment and what are the odds that you may have a side effect or a bad outcome? What's your understanding of what will happen if nothing is done at all? And some of this will mirror kind of motivational interviewing concepts where you're engaging the patient to describe their understanding and their choices as opposed to them feeling pressure by you to make a particular choice, okay? Questions to determine the ability of the patient to appreciate how that information applies to their situation, all right? Tell me what you really believe about your medical condition. Does the patient have a delusional belief about their medical condition? Have they refused to accept their medical condition, okay? Why do you think your doctor has recommended treatment or test A or B, okay? Do you think it's this specific treatment or test is the best treatment or test for you? Why or why not? What do you think will actually happen to you if you accept this treatment or if you don't accept it. Okay, so again, very kind of specific questions that give us a much more concrete understanding of the patient's understanding and their ability to reason, which is critical. So here are some of the questions about their ability to exercise reason, right? What factors or issues are the most important to you in deciding about your treatment? What are you thinking about as you consider this decision? What's your hierarchy? You know, how are you making this determination? What's most important to you? How are you balancing the pluses and minuses of treatment? Do you trust your doctor? Why or why not? Sometimes paranoid patients who are psychosis can have a primary or presentation of paranoia. If you speak to them about any and everything else, they can appear perfectly intact. And you only get some of the paranoid delusions out if you poke that specific bear. So asking if they trust a doctor is one window to open the chance that there may or may not be the presence of that. What do you think will happen to you now? You know, and then these are questions to help determine the ability of the patient to communicate and express a choice clearly. You know, today we talked about a lot. You got a lot of information that was presented to you. Have you decided what medical option is best for you right now? We discussed a lot of choices. What is it that you want to do and why? Okay. These are some testing tools that have been used and can be used to determine medical decision-making capacity, but I want to caution you they're not required or necessary, okay? You don't have to use these in your guide, but they're important guides, and I think they provide important information for people who are more interested about the process, okay? So, an important key learning point. Documentation of loss of capacity can only happen by a physician. Advanced directives are not in effect, and a durable power of attorney for healthcare has no legal role until the lack of capacity is documented as an order in the medical record, right? I've recently had to help to consult with the ethics committee on a situation like this where they asked me to do a chart review. And some of the concerns were around a misunderstanding that the patient, because they were a psychiatric patient, automatically lacked medical decision-making capacity. And I've had to explain to them, listen, this is the way it's supposed to work. Unless it's assessed, documented, and it's placed as an order, then we can't presume that. Sometimes this is a test question too that you'll see, so be wary of that. All right, surrogate decision makers. So in most states, there's a hierarchy. It tends to start with the spouse, then the child or the majority of adult children, and then parents, siblings, and or the nearest living relative. Notably in New Hampshire, there's no hierarchy. They make an independent assessment about who's best suited. That's it. New Hampshire, live free or die. You know, they live by their own rules sometimes. All right, so court-appointed guardianship can be expensive. It can be complex. It can take days to months to obtain. Court-appointed guardians are not trained in palliative or end-of-life care, which is important. And it's most efficient if a family member is available to be the petitioner. They know the patient the best. They know their values. They're more likely to be competent and comfortable making those critical decisions. So now I'm going to open the floor to ask any questions about medical decision-making capacity before we move forward to the next phase.
Dr. Blue, I had a quick question for you.
Sure.
So you particularly mentioned delirium.
Yes.
So that is a fluctuating status.
Mm-hmm.
If one were to assess the patient at a time when they are cogent and able to presumably answer all of these complicated questions,
Mm-hmm.
would that stand since they do tend to fluctuate?
So it wouldn't stand in and of itself. So it would not in and of itself, it would require follow-up evaluations. So in other words, in that you would document that they appear to have it, and any medical decisions they make while they're in that state of mind would be considered valid. However, the treatment team, and what usually happens from a functional standpoint, is the treatment team will contact psychiatry later and say, hey, you said this person has capacity, and now they're making decisions that don't appear to make a lot of sense. We can barely awaken them, you know, or they're behaving in a strange manner. Can you come back and assess the patient? And we frequently do. And whenever a patient has delirium, we put them on the consult list and we follow the patient while they're in the hospital each day for that reason. And you also want to try to change the time of day that we assess those patients because of that. Because patients with delirium, if you come back at the same time of day every day, you could be catching them at their window of clarity and missing some of the times where they may not be as functional. So it would stand temporarily, but it would have to be assessed daily and documented daily. And that's why I mentioned specifically that it takes more than one visit in some cases.
So I'm particularly asking if there's a surgical procedure or something major that's planned. So today you catch the patient in a cogent state around the procedure and appears to have capacity, or presumed capacity exists, because
Right.
you have to sort of not have it to you're presumed innocent, presumed capacity. But then they end up going into other states of mental status changes. However, the procedure is something that they can't sort of on and off get them on the surgical list, etc. So how does that work?
Well, we would document that the patient provided informed consent and appeared to possess medical decision-making capacity at the time of the evaluation. Once that's documented, they're able to schedule and move forward with the procedure, and they would take mental status changes by the patient in the interim as need for a further medical treatment or a treatment of the mental status. But they would still be able to proceed with the procedure since they possessed capacity at the time they consented. The more difficult situation, though, and I think is underneath the question you're asking, is, so what happens if the patient appears to have capacity, refuses the procedure, the clinical situation gets worse, their mental status gets worse? Now what do we do? Is that kind of like what you might have been?
No, but I think that's a very good example that to get some input on.
Sure.
The other, and I don't want to take up a lot of time, the other quick question is, how detailed do you document in the EMR? I mean, the range of questions you identified in discussing to assess capacity is very, very detailed. There's a lot of information the patient could share. However, I'm wondering how much detail you're going to put in the actual consult note.
That's awesome. I'm glad you asked that question. So what I usually do is I use the 4 prongs of medical decision-making capacity, and then I will state my opinion. The patient appears to have, possess, or lack medical decision-making capacity as evidenced by. And then I'll use the words of the patient and how they responded specifically to show that their demonstration to understand, to reason, to appreciate the differences between the risks and the benefits, etc. So I'll use their words as evidenced by the patient's capacity to say X, Y, or Z. So it's not a very long note, although it sounds like it, but I take each of the decision-making criteria and then I describe why, in my opinion, the patient possessed or lacked the medical decision-making capacity. I may not list out every single question that I asked them, but the questions or the responses that were pertinent, that demonstrate understanding or lack thereof, I'll document those. And then into the other instance, normally if the patient's medical decision-making, so let's say that they refuse, right? And at the time they appear to possess, and then the clinical situation gets worse, I reevaluate the person. If I'm unable to demonstrate that they possess medical decision-making capacity, I may document that they lack it, especially if it's a clinical emergency, and provide consent for them to be able to move forward.
Dr. Blue, we do have a couple of questions from our chat.
Sure.
Lisa Blevins over at the VA is asking, can you please clarify, does it require an MD to judge capacity, or what level of provider is allowed to assess this?
As long as the provider is an MD, they can assess capacity.
So it does have to be an MD, but it doesn't matter the specialty.
Correct.
Okay. All right. Thank you. And then the other question from Dr. Azaza, he's asking if you can describe or you can explain how to describe a patient's judgment on the mental status exam when you feel they have the capacity to make bad decisions, but you don't agree with those decisions.
Great. So first of all, the judgment may still be intact if they're making a decision that's logical with respect to their hierarchy of values. So we can, from a clinical standpoint as a physician, believe that this procedure, this treatment, this test is in the best interest of the patient based on our knowledge and experience and training. But the patient may have other hierarchy of values, religious values, cultural values, relationship values, quality of life values. Patient may say, well, I am all for extending my life, but my quality of life may be more important to me than my quantity of life. Whereas the physician, it may be all about the quantity, you know, or how much. And so those types of disagreements, right? Those types of where you may question the patient's judgment, you would still describe the patient's judgment as intact. Okay. Now, if a person is choosing to have an intervention that has a high risk of side effects and negative outcome and a low risk of benefit, okay, and or the patient is refusing a situation where there's a low risk of harm but a very high risk of benefit, you can then describe the patient's judgment as potentially impaired. Okay, but even then, on that sliding scale, you would wonder whether or not they possess medical decision-making capacity. The rest of the evaluation helps us to figure that out. So if they're able to reason, they're able to communicate a choice, they're able to understand and appreciate the nature of the healthcare decision and how it relates to them personally, and they're making a decision that's being influenced, they're giving more import to values that may not be as important to us, but is still logical, judgment's intact, okay, but the patient's making a decision, they still possess medical decision-making capacity. If the person appears to have impaired judgments due to substance abuse, chronic substance abuse, or substance intoxication, brain injury, delirium, then they would be impaired on both scales.
Excellent. A couple of other questions. Can you, after you make an assessment and document that assessment of capacity, can a surrogate or a power of attorney disagree with that decision or challenge your decision?
Absolutely. So remember, when we have a surrogate decision maker, that surrogate decision maker is independent. If they don't believe that the medical decision is in the best interest of their relative or whoever they're surrogating for, they still have the right to refuse it. And so the consent part is real. So they can refuse the treatment.
Okay, and then another comment from Dr. McPherson is actually one of our clinical psychologists over at the VA. And she's actually, just to check, saying that she believes psychologists can actually determine capacity as well.
We probably want to investigate Tennessee specifically. I've noticed that there's been probably in the last 3 to 5 years a significant role for mid-levels and psychologists to play in roles that they didn't used to be able to. At the time that I constructed this and last time I looked, you had to be an MD, but it could very well be that in Tennessee they allow psychologists to assess medical decisions.
Okay, okay. That's all we've got for now.
All right. So the next topic for discussion is for us to be able to understand the differences between a clinical and a forensic psychiatric assessment. Figure since I'm a forensic psychiatrist and medical decision-making capacity kind of touches on that a little bit, I might as well kind of open the door to what an introduction into forensic psychiatry might look like, okay? So the important first thing you want to understand is the difference in the training. So all forensic psychiatrists are clinical psychiatrists first, right? So we understand that. And during our clinical training, we're taught to evaluate the patient through a thorough psychiatric assessment, interviews. We try to gather collateral information from family members, friends, hospital records, etc. But our stance is a little bit different. And the majority of the information we grab, the importance of our communication with the patient is paramount. In forensic psychiatry, maybe not so much, and I'll explain that in a second. So we're taught to listen, we're taught to empathize with the patient's concerns, to accept the patient's symptoms as valid, okay? Lying, deceit, exaggeration, malingering, they happen, but they're usually secondary matters of clinical concern. And in the majority of the times, we tend not to see or address those. All of us who've done inpatient work have enjoyed the benefits of having a malingering patient now and then, and patients will malinger. Even in the outpatient setting, sometimes patients are incentivized to malinger for better benefits, for increased benefits, for access, etc. But for the most part, we're taught to accept what we receive as far as information from the patient in our clinical training. Forensic psychiatrists are required to take a more skeptical stance towards the patient's description of events, all right? When a patient presents in a medical legal context, there are obvious motives to lie, exaggerate, distort symptoms, and events. These are what I call threats to validity that we have to deal with that in a clinical presentation you see less frequently. So the patient's versions of events, the background and symptom description have to be corroborated via collateral sources of information. So as a clinical psychiatrist, whatever the patient describes to me, I'm going to try and accept it as valid and see where it leads me as far as a diagnostic formulation and an eventual treatment plan to help the patient. As a forensic psychiatrist, you have to presume that the information you're receiving from the patient may not be true. And so you want to try and corroborate everything you can, and you have a higher degree of confidence in information that you can corroborate than you do with uncorroborated information. So it's not that what the patient says is unimportant, it's just significantly less important in a forensic evaluation. So the scope is also very different. Clinical evaluation tends to be very narrow in scope, okay? We're looking at the presenting problem. We're trying to treat a specific issue or set of issues. A forensic psychiatric evaluation has a very broad scope. We're doing more than just assessing the individual in front of us. We're assessing the available records, witness statements, potential police reports, depositions, video footage, crime scene footage, depending on the nature of the case. So there's a much, much broader scope. The importance of the patient's perspective is different, as I kind of described previously. Voluntariness is another situation that we face. So oftentimes when a patient presents in a medical legal context and you're there to perform an evaluation, they may not be voluntarily consenting to be there. They may have to be there as a requirement by law. Some of us on the clinical side will see this. Sometimes you have people who are forced into treatment, probation is directly, whether or not they're satisfying their probation terms or whatever, or directly related to whether they follow up with treatment, et cetera. In some states, you have outpatient programs that are enforced by the justice system, et cetera. But for the most part, the voluntariness is a big separation. The threats to validity that I'm going to go into a little bit later. Relationships and dynamics, that's a big one. So, when you have a patient in a clinical setting, you're the patient's doctor. You have an official doctor-patient relationship. Okay, and there is a therapeutic alliance that you're trying to build and maintain. When you have a forensic assessment, you're not the patient's doctor. You do not have a doctor-patient relationship. You're not there to care for the patient. You're there to perform an evaluation, and there is no therapeutic alliance, so it's very different. The pace and the setting also can be very different. Clinical evaluations oftentimes can be time limited. For those of us who practice inside and outside of academic institution, there may be more or less pressure on you to complete evaluations and see patients within a certain amount of time. The pace can be a little bit more hurried. In forensic evaluations, it's a much slowed down pace. And the setting may be completely different, even in a correctional facility at times. So the forensic clinician has a transition from the traditional role of treating physician, who the patient's best interests are the most paramount, and identifies ourselves as agents of the justice system where truth-telling is the basic duty, not so much a responsibility to care for the patient. So it's defined as a subspecialty of psychiatry in which scientific and clinical expertise are applied to legal issues in legal contexts where we embrace civil, criminal, correctional, or legislative matters. You're often presented as an expert to opine on specific questions by the court. So the court, is this person competent to stand trial? Should this person be considered not guilty by reason of insanity, or should they be criminally culpable for actions that they engaged in while they were allegedly mentally ill? Okay. Has this person been injured and suffered psychiatric harm or psychological harm, and can they return to work? These are something kind of like that. Was this person addicted to a particular substance, and did that addiction, in the old nomenclature we would use as a severe use disorder now, but the law is often behind medicine in the terminology. And does that severe use disorder result in death or harm to the patient, or was it a substantial contributing factor? So these are some of the common questions that you're asked to opine on as a forensic psychiatrist. And so you're using your clinical psychiatric training and background as a ground step, as a foundation, in order to be able to assess the patients. And at the same time, your foundation in the law from your forensic training to be able to provide a specific answer to those questions. So we function as an expert within the legal process. Oftentimes, one of the big cautions for any of you who may be interested in doing forensic psychiatry, and I will say this several times during this talk, is the importance of truth telling and not allowing agency or whoever it is that retains the expert to be able to manipulate or control your opinion, okay? You should be honest in your opinion, tell the truth, even if it is bad news for the person that's hired you. This is very dangerous for the profession in any other circumstance, okay? So just because one is paying a retainer or a check or has hired you, it doesn't mean that your opinion should be beholden to who's hired you. You still need to strive for objectivity and honesty. And that adversarial nature of our process, it presents hazards because the average person, if you're honest, they want to win, right? You want to win, right? So you want your side to be correct. So you have to avoid being sucked into that, okay? What is the true answer to the question? What is it that I'm being asked to be able to opine on? And to the best of my ability, based on all of the available evidence, my clinical psychiatric assessment, my forensic psychiatric assessment, what do I think is the truth here? And we have to be careful about allowing attorneys and advocates to twist our assessments into something that better suits their purposes, but may be a farther distance from the truth. And trust me, it happens. You really do have to work against it. So it's our responsibility as a forensic psychiatrist to minimize these hazards by carrying out the responsibility in an honest manner and striving to reach an objective opinion. So in our ability to do that, we're going to use all the data that we have available to us, but there should be a hierarchy of information that our opinions are underpinned by and based on, okay? So it's just like any other analysis, and anybody who follows politics will be able to empathize with this. Oftentimes, individuals with an agenda can focus on any given fact or data set in an effort to bolster opinion that may not necessarily be true or relevant in that way, but they got a set of facts that bolster it, and so that they kind of stick to that and use that. The forensic psychiatrist is supposed to look at all the facts and have a hierarchy of most reliable to least reliable, right? And be able to separate the difference between clinical inferences and impressions from clinical facts. And that's what I kind of describe on this side. So there's verified information, there's unverified information, there's what I think based on my previous experience as an expert, and then there's more heavily relatable and reliable information that doesn't really have anything to do with my opinion. These are more clinical facts. And so you have to organize those in a hierarchy and use those to support the opinion that you come to. One of the most dangerous things a forensic psychiatrist can do is to pretend to be more confident or to know more than what they really know. I've seen a lot of really good forensic psychiatrists get caught in this trap. As doctors, we can be very uncomfortable sometimes saying, I don't know, or I'm not sure. You always want to kind of be the expert. You want to know, you know. And there's some things that you're not going to know definitively. So we have to admit that. There are some things that we're going to base on clinical inferences, all right, as opposed to clinical facts. And we have to admit that, both on the stand and in our report writing. So here we go into whether or not the testimony, providing testimony, and this is where I usually like to have a show of hands, you know, like if I got a room full of residents and attendings and students, it's like, you know, if you had to guess, how many of you think that providing expert witness testimony is practicing medicine, you know, versus not, you know, because, you know, there's a solid argument to be made on either side. Well, I don't have a doctor-patient relationship, right? I'm not actually caring for the patient or providing any treatment, so maybe I'm not practicing medicine. On the other hand, you are evaluating the patient and you're testifying about that in court, and you're doing that under the auspices of a license to practice medicine in some jurisdiction, right? So it's hard to, and I'll get into that in a little bit, but it's hard to talk about forensic psychiatry without talking about malingering, okay? So according to DSM-5, the essential feature is the intentional production or feigned or grossly exaggerated physical or psychological symptoms, usually motivated by some external incentive. So I want to avoid work. I want to avoid being prosecuted for something. I'm trying to get financial compensation, or I'm trying to get drugs, etc. Some of us who've enjoyed the benefits of taking care of malingering patients have seen some of that. And in some contexts, malingering is not always described in a pejorative fashion. For example, malingering can represent adaptive behavior if you're feigning illness while a captain of the enemy during wartime, for example. So this is when we should strongly suspect it, all right? One, is the case happening in a medical legal context, all right? In a forensic psychiatric evaluation, that's almost always yes. And so you always have a reason to suspect malingering, which is one of the major differences between a clinical assessment. Is there a marked discrepancy between the person's claimed symptoms or disability and the objective findings that we're able to see in the record, okay? And is there a significant lack of cooperation during the diagnostic evaluation process and during the treatment regimen? And then lastly, the presence of good old-fashioned antisocial personality disorder, which I'm going to talk a little bit about too, okay? So people with antisocial personality disorder, for those of us who are less familiar with it, can present a unique and difficult challenge to both clinical clinicians and forensic clinicians. They tend to demonstrate a pervasive pattern of disregard and violation for the rights of others. They don't like to conform to social norms with respect to lawful behaviors. They frequently use deceit as a tool, impulsivity, failure to plan ahead, irritable, aggressive. I find that there's almost two types of antisocial patients, okay? So you have your higher functioning intellectual antisocial patients. They're less bullies. They're not really about causing physical harm to people. They're superficially glib. A lot of times they can be charming, for example, but they'll still use deceit, and they can still demonstrate a lot of impulsivity. You'll see that. A reckless disregard for the safety of others, consistently being irresponsible, repeated failure to sustain consistent work behavior. And some of us, unfortunately, have probably enjoyed the benefits of working with some high-functioning antisocial personality disorders. Hopefully you haven't. I know that I've enjoyed that benefit. We want to make sure we take a look at the exclusion criteria where the individual is at least 18 years old, that we have some evidence of conduct disorder with onset before age 15, and that the occurrence of antisocial behavior isn't exclusively during the course of either a major psychiatric diagnosis like schizophrenia or mania, okay? So back to my question a couple of minutes ago, right? Is providing expert testimony in the practice of medicine? I usually take a little poll here. I don't get a chance to do it today. But I'd be super curious to see what you guys think. So to date, very few cases have challenged the licensing board's authority to discipline physicians for fraudulent expert witness testimony. Okay, one of those cases is the Missouri Board versus Levin, okay, in 1991. There, the court actually concluded that the board lacked statutory authority to discipline the expert witness. So what you're going to find is it really rises and falls on how the state defines the practice of medicine, okay? So however the board defines the practice of medicine in that state, and I'll tell you about Tennessee, can largely determine whether or not it's officially considered the practice of medicine, but the AMA has their own position on it that I'm going to go through with you. So in this instance, the physician in question lied under oath on two separate occasions. Okay, both falsehoods were related to board examinations. He first testified that he had passed his boards on the second attempt, and then in an unrelated trial later, he claimed that he passed on the fourth attempt when actually he had passed on the fifth attempt. So a lot of times witnesses don't realize, when you serve as an expert witness, the attorneys, they go back and look at everything you've ever said under oath, any deposition, everything you've ever said, they're going to comb through it. So they found this discrepancy and they said, hey, they brought this to the board, say, hey, this guy's misrepresenting his credentials in court. So in Joseph B. MDV versus the DC Board of Medicine, they upheld the state's authority to discipline the physician for fraudulent expert witness testimony. And you can see the board getting in his face here on the slide. So in this case, an emergency medicine physician licensed in Maryland and DC falsely testified that he was board certified in thoracic surgery, that he ranked first in his medical school class, and that he was a member of certain professional societies that he wasn't a member of. Good. So the AMA's position is that expert witness testimony is the practice of medicine. And as a logical corollary, boards should have the authority to discipline physicians who disobey ethical standards when they give testimony, okay? They also gave specific recommendations. So this is a huge hot button issue. You guys probably don't know this, but you have to remember, forensic psychiatry is a fairly young specialty, really came more prominent in the 1990s. And when it exploded onto the scene, it presented a lot of these issues that the AMA and other organizations had to wrestle with. It's like, well, how do we discipline them? Are they practicing medicine? You know, how do we handle it? You know, it wasn't patient care, but you could still argue that they did harm to this patient, et cetera. So this is some of the recommendations that came out of that. So they encourage each state medical society to work with the state licensing boards to develop appropriate and effective disciplinary measures for physicians who provide fraudulent testimony. Then they want to provide legal and advocacy support to those medical specialty organizations who seek to devise programs to design. So there was this huge push. What's underlying this, history kind of tells everything, all right? So what's underlying this is that you had a certain subset of experts who were out there doing things that were unethical and inappropriate. It's an extremely lucrative specialty, so they were getting paid and willing to say whatever they could get paid to say in some instances. And it got so egregious and it became so difficult for some of the state medical boards to discipline them because of the gray area as to whether or not it was the practice of medicine or not. So where the AMA got on board, the American Academy of Psychiatry and the law got on board and all came up with specific recommendations on how to police or appropriately monitor the behavior of expert witnesses going forward, okay? They also want to continue to study and work with interested organizations to address the inherent difficulties in conducting peer review. So if you can imagine, you know, if you work in a hospital, peer review is pretty easy to accomplish. You have peers who can review the records and opine on the specific data sets. In this instance, how do you peer review a fellow forensic psychiatrist? There's no charts, you know, to be able to review. They're not providing care. You're looking at deposition video or transcripts from trials. It's more challenging. So this is their way of admitting that and saying we need to do better, okay? They continue to educate physicians about ethical guidelines and professional responsibility regarding providing expert witness testimony. And what about Tennessee, right? So I promised you I'd let you know. So the legal definition, the definition of the practice of medicine in Tennessee can be construed as broad enough to include expert witness testimony, according to the American Academy of Psychiatry and the law. So it isn't explicitly stated, but the way that they describe it, it definitely could be consistent. And so Tennessee can discipline physicians, or more likely would be in a position to discipline physicians who are dishonest in their testimony. So in summary, the forensic psychiatric assessment varies from the clinical assessment in some important ways: the scope, the importance of the patient's perspective, the voluntariness of the evaluation, the individual and specific threats to validity, the relationships and the dynamics between the individual and the doctor. I can't say patient, he's not really caring for the patient, and the pace and the setting. Okay? So we have to transition from the traditional role of treating patients, where we're thinking about what's in their best interests, and be more of a truth teller, where we're answering specific questions as an agent of the justice system. And the AMA's policy states that expert witness is the practice of medicine, in their opinion, and that as a logical corollary, the licensing board should be able to discipline physicians who engage in egregious behavior. All right, time for questions.
Dr. Blue, I had one question. So can one, I guess a client of in a court case, can they potentially sue an expert witness if they are found to have been lied in some fashion about their expertise or anything else that they would have testified to under the oath? Kind of like you can apparently sue lawyers, although I don't know how successful you'd be, but.
Well, actually, there's a good chance that they would enjoy some success. So if it's demonstrated that an expert witness did lie on the stand, and that lie resulted in some sort of legal, financial, or other harm to the patient, they could sue. It wouldn't be a malpractice lawsuit per se, and that's probably where the confusion might come in, but they definitely could have civil liability for that, without a doubt. The issue, I think, for the AMA and a lot of the state licensing boards is they want to be able to own that discipline. You know, they want to be able to say, hey, you know, you're practicing within our guidelines, within our purview, under the auspices of being licensed by us. And we want to be able to police inappropriate behavior, you know, lying on the stand, et cetera. And for a while, it was a wrestling match. It was hard for them to do because of the unique slice that forensic psychiatry represents. But definitely you could. I'll share a brief story in response to that question. I was involved in a case that was a death penalty case where it was not guilty by reason of insanity evaluation. And I opined that the defendant did not satisfy the statutory requirements for a not guilty by reason of insanity plea. And they were later convicted of the crime. And after they went to prison, they filed a complaint with the state medical board, okay, against me because they didn't like my testimony, because my testimony contributed to them being convicted. But the state reviewed the case and reviewed the testimony. I didn't make any false statements during my testimony. My opinion appeared to be supported by the facts and evidence, and they dismissed the complaint. But those kinds of things can definitely happen. I might have put everybody to sleep. Sorry about that. It is 12 too.
There was some continuing discussion, Dr. Blue, and please forgive me if I do not pronounce your name correctly, but it's Thomas Schacht, is a clinical psychologist apparently, and he, in the state of Tennessee, has said that he does routinely do capacity assessments, and it says that anybody in theory whose scope of practice in Tennessee includes obtaining informed consent can assess competency or capacity. I don't know, maybe he might want to explain.
It would be capacity. It wouldn't be competency.
Capacity.
In the legal context. And from logically, that makes sense. A lot of states have been a lot more restrictive. But I've noticed a trend, like I said, over the last 3 to 5 years, where more of those types of things are being delegated and are being allowed to be like mid-levels and psychologists to be able to participate in those. So I wouldn't doubt that.
Does anybody have any other questions? Great discussion.
Everybody's hungry.
Going once? All right, well, I'm sure that Dr. Blue would be more than happy to address your comments or questions offline as well. We so appreciate this timely and excellent information as residents. We do get called to do this quite a bit on our consult service. It's very helpful, the capacity piece of it. And then just really interesting, we don't get a lot of exposure to forensics. So we're very grateful for that. But great lecture. Thank you so much.
Yeah.
And at this point, I think we will go ahead and conclude. Guys, thanks for being here.
Thanks, everybody.
Thank you.
Thanks, Dr. Blue.
We appreciate it.